I'm just saying it is moving on. It is moving on. So good morning to all. Today myself, Dr. Amit. So today we are going to talk about the follow-up of the high-risk neonates and what we can add on to these high-risk babies. So for the introduction, it is the first 100 days, that is from conception to 2 years of age, that was the most sensitive and the crucial time in the development of the brain. At that time, the neuroplasticity happens, and after that, the neuroplasticity declines. So, if at this time the baby got less stimulus, so the all synapses got pruned out and will be lost for the lifetime. So the deficit in the early childhood development cannot be effectively repaired when intervention are done after 24 or after 2 years of age. So what things require and what are the outcomes that require the intervention? So we have to see the extreme low birth babies, babies with moderate to severe asphyxia, babies with the severe jaundice requiring exchange transfusion, hypoglycemias with the neurological signs. So these babies are more chance to have cerebral palsy, the motor deficit, hearing impairment, and the blindness, and these babies should be followed. So this was the studies, the ACTA from the ACTA Pediatrics. In that, they have seen the follow-up of high-risk neonate discharged from the ICU up to 1 year of period. It was done by the Surinder et al. In that, they have seen that all the high-risk neonates should be followed up and assessed to identify the growth failure and neuro disabilities so that early intervention can be done. The other studies, which were a prospective of follow-up studies of high-risk neonates discharged from the SNICU and NICU, in that they have seen that the follow-up of high-risk cases, such as those with prematurity, low birth weight, parenteral asphyxias, sepsis, pathological jaundice, neutral convulsions, are very important as it can help to identify the infants who would require early intervention to minimize the disabilities. So the follow-up is always a continuation of the process that starts from the NICU and that leads to find out the babies who require the early intervention and can be followed up. So this follow-up study is provide a continuum of specialized care to the sick babies discharged from the NICU, identifies the early deviation of the growth, development, or behavior from the normal, provides support and intervention as indicated, and also it provides a long-term follow-up that will enhance the understanding of association between the risk factors, therapies, and intact survival. It also provides a database which allows the objective anticipatory guidelines for the parents and to know about the actual local scenarios. So the plan of action for the high-risk babies are to identify the high-risk babies and risk stratification that we'll discuss in the next slides. Early stimulation, formal assessment at the discharge, early intervention, follow-up, specific management, and counseling. So this stratification, in that we have to see from the prenatal to natal and postnatal. The prematurity and the low birth weight are the most important risk factor. Apart from that, as we discussed earlier also, any babies having asphyxia, malformation, ELBWs requiring exchange transfusion of the jaundice, shock, need of ventilation even of single days, sepsis, NEC, chronic lung disease or BPD, or babies require postnatal steroids, baby having hypocarbia or hypercarbia, and the babies having low socioeconomic histories, they should have to be followed up. So what they have seen, so for the sepsis certification, Stoll et al. That have described that The babies with neonatal infection have lower mental developmental index, lower psychomotor developmental index, lower visual problem, cerebral palsy. So in these babies, the CNS incidence or the incidence of the CNS damage is almost 20 to 60%. And if the baby is having gram-negative meningitis, then the incidence of hearing loss is 15% and 30% suffered the developmental delay. And as we discussed NEC, so NEC stage 2 or higher, they have more chance of neurodevelopmental impairment. And overall NEC, the 40%, 45% of the children were neurodevelopmentally impaired. Apart from that, these babies having high risk of cerebral palsy, visual impairment, cognitive deficit, and neurodevelopmental impairment was 2 to 3 times higher if the baby having the Bell's NEC staging of 3 or requiring surgery. As we discussed invasive ventilation, in that either HFO or conventional ventilation, even for 24 hours, what was seen that at 24 months of age, when they have followed, they have seen that the baby's incidence of severe neurodevelopmental disabilities is 9% and other disabilities is 38%. And the prevalence of disability was similar in children either receiving HFO or conventional ventilation. So any babies on invasive ventilation, even for 24 hours, either HFO or conventional ventilation should be followed. For the BPD stage 2 or chronic lung disease, they have also chance of risk of development delay because this BPD is associated with the hypoxia and associated with the neutral brain lesions. Now, NNF has done the risk categorization in the high risk, medium risk, and low risk. In the high risk, they have done the extreme preterm, 28 weeker, less than 1,000 grammer, with the severe morbidities like NEC, IVS more than 2, ROP requiring treatment, PVS, parental asphyxia or HIE, generally grade 2, more than grade 2 or 3, maybe requiring surgical conditions, maybe the small for gestational age, ventilation for more than 24 hours, persistent hypoglycemia, neutral seizure, meningitis, and shock requiring supports. The moderate and the mild risk categories are on the weight basis. So the weight 1,000 to 1,500 gram is moderate risk and 1,500 gram to 2,500 gram is mild risk. With HIE grade 1 is mild risk and HIE grade 2 is moderate risk. Hypoglycemia, that is GRBS less than 25 is moderate risk. Neonatal sepsis, jaundice requiring exchange transfusion, IVH less than grade 2, and suboptimal home environment. With previous sibling history of delayed development or CP or seizure, that comes under the moderate risk. Whereas IVH grade 1, neonatal jaundice, suspected sepsis, or transient hypoglycemia comes to the mild risk. Now they have also identified the babies who requiring the neurodevelopmental or they have more chance of neurodevelopmental delay. In that, the severe one is the babies having fetal distress, the gestation age of less than 33 weeker, the weight of less than 1,500 gram, suboptimal transport, not receiving enteral steroid, Apgar score is less than 3 at 5 minutes, Levine grading of 3, ventilation requirement of more than 7 days, associated with the pneumothorax, hypocarbia, apnea requiring resuscitation, reflective shock, having HSPDA, symptomatic hypoglycemia, seizure, meningitis, connectitis, chronic lung disease, ventricular megaly or cystic ventricular leukomalacia, abnormal neuroconsumption at the discharge, and parents are more concerned with the neurodevelopmental delay. So, where to follow up and to whom this follow-up can be done. So, for the mild risk, it will be done by the primary care or pediatrician in their own clinic. They will first follow up for the deviation in the growth and development. For the moderate risk, it will be done by the pediatrician, neonatologist, and involvement of the developmental therapist. That should be done in the developmental unit. They will screen the developmental delay and also manage the intercurrent illness. For the high risk, it is a multi-specialty unit. There should be a dedicated child developmental center that can see for the developmental delay. So, active surveillance starts when the baby is in the NICU. So it starts with the pre-discharge, with the medical examination of the neurological, neuroimaging, the term gestation, screening of eye, ROP screening, hearing screening, screening for the congenital hypothyroidism, screening for the metabolic disorders, and also assessment of the parent's coping and the developmental environment. And then the follow-up. With that, we have to examine for the nutrition, growth, immunization, neurological examination done with the different scoring system, developmental assessment that we'll discuss in the further slides, physiological assessment for the squint, refraction, screening for the hearing, language, speech, for the behavior, cognition, and intelligence. Also management of the other medical modalities, and also we have to follow the guideline of infant and young child feeding guideline for the complementary feeding. So who needs and at what time the follow-up should be done? So the first follow-up should be done within 72 hours after the discharge, and then every week till weight of 1.8 kg, and then at the term gestation is. At the risk infants, after term gestation age, it should be done till 2 years of age at 3, 6, 9, 12, and 18 months. Some also prefer to do at 4, 8, 12, and 18 months. It depends upon the unit policy. But it cannot be done on more than 6 months apart. After age of 2 to 3 years, when the child is progressing well, assessment could be done annually till the school entry, and then bimanually in the middle childhood till 10 to 8 years of age. Now, what to do and how to screen for the growth? We have to see the weight, length, and head circumference that should be plotted on a standard growth chart. The birth weight and discharge weight must be compared to know about the deviation. The weight centile must be interpreted against the length centile, and after 40 weeks, the WHO growth chart should be followed. Poor growth can affect the neurodevelopment, so all babies should be followed for the weight gain. Apart from that, the second most important is the head circumference. So it is the most simple tools that can predict the abnormal brain growth. So it should be recorded and plotted serially every health visit till 2 years of age. And we have to see at the chart whether it is macrocephaly or macrocephaly, and any static or dropping centile of head circumference in relation to the length centile is variation. So this is the study which have seen the head circumference on the preterm developmental outcome. It was done by the Kamini Raghuragam et al. In that, it was a retrospective cohort study that was done in the less than 29 weeker. In that, they have seen the head circumference at the time of admission to discharge to follow up at 16 to 36 months, and admission to follow. In that, they have seen that the poor HC growth during the neonatal and postnatal discharge period are associated with the motor and cognitive delay at 16 to 36 months. Apart from that, at every visit, we have to see about the nutrition, how much breast milk the baby is taking, any fortifier is used or not, or what formula or parent formula is used or not, and how much calorie and protein baby is receiving, and how much deficit it is. Also, screening should be done for the osteopenia prematurity at 6 to 8 weeks of life due to the poor bone mineralization, and the vitamin D, calcium, and phosphorus supplementation should be done. The iron supplementation can be started at 2 to 3 weeks of extreme preterm babies, and apart from that, at the near term, 4 to 6 weeks, and should be continued till 1 to 2 years of age. The recommended dose is 3 to 6 milligram per kg per day of elemental iron. The supplemental feeding can be started at 4 months of age, but one should not be hurried in starting hematopoietic foods too early. At all the visits, the immunization should be reviewed and it should be done with the chronological age. Hepatitis B, one should be weight till weight of 2 kg. Physical examination should be done at every visit to see for the hip examination with the Barlow and outline test in a dysmonorrhea, sign of intrauterine infection to see the IOGR, macrocephalus, and other neurocutaneous markers. Also, we have to see and address for the other infections or comorbidities that may lead to decrease in the weight or length, just like chronic lung disease, gastroesophageal reflux disease, and reactive airways disease. For neonatal examination, it is a useful predictor for neurodevelopmental disabilities on the follow-up. So it should be done at the routine clinical examination. So isolated examination is not so much informative. So we have to do in a club, and it should be done at every visit. One to the NNF, the one during the first 6 months, one during the second 6 months, and then once yearly. So what is the prediction? So abnormal tone of the limbs, neck, and trunk that increases the risk of CP by 12 to 15 folds. Diminished cry for 1 day increases the risk of CP for 21 folds. And absent or a weak suck increases the risk of CP of 14 fold. Whereas need of gavage feeding on tube feeding on discharge increases the CP of 16 to 22 folds with the diminished activity at least for 1 day, increase the increased risk of CP of 19 fold. This is the chart that we have to follow. What should be done at the time of screening? So at 40 weeks of critical gestation age, we will do for the NSG, beta for the hearing, HNNE that we'll discuss in the next slide. For the neurobehavior assessment, that is Napier scoring, at 4 to 6 months, high, DDST, CDC grading for the head control, 7 to 9 months, high, Bailey is 4, CDC grading setting for the sitting and for the language. At 12 months, again high, Bailey is 4, CDC grading for the standing. Language, AMCHET, and 18 months, again high, Bailey, list, AMCHET, and dose and motor function test. So now coming to the assessment of the tone on your assessment. The first one is the ML Tyson score. It can be done when the baby is inside the NICU also and afterward also. So this is the diagram that shows how the development of the tone in the neonates with the gestational age. So what we will see from 28 to 40 weeks, the acquisition of the muscle tone and the motor function proceeds from caudal to the cephalic. So from the leg to the hands, the tone usually increases from 28 to 40 weeks. And after 40 weeks, this process is reversed and it just leads to relaxation and the motor control proceed downward in next 12 to 18 months in a cephalocaudal function. So there is a decrease in the muscle tone in a sequence of cephalocaudal weeks. So this ML Tyson scoring includes neuromotor, neurosensory, neurobehavior, and head growth. This should be done during the NICU stay also at term gestation or 36 weeks. At test schedule also done at 3, 6, 9, 12 months with a good screening test. And predictive value at 3 months of examination for the normal outcome is 93%. But the tight angle, that is tight popliteal angle at the 4 months do not always predict the abnormal outcome. But if it is persistent hypertonia, at 8 to 12 months of age, it is associated with the poor outcome. So this is the chart is showing the active tone of that we have to see. It is 28 weeks, 30 weeks, 32 weeks, 34 weeks, 36 weeks, and onwards till 40 weeks. In that, we have to see the tone of the lower extremities, trunk, neck extension, and neck flexor. This chart is available online. This is for the passive tone, in which we have to see the posture of the baby with respect to their gestation age at 28 weeks, 30 weeks, 32 weeks, 34, 36, 30, and 40 weeks, in which we have to see the posture, heel to ear maneuvers, popliteal angles, dorsiflexion, scarf sign, and return of the flexion of the forearm. and also to see the reflexes of sucking, rooting, grasp, moro, cross extension, and auto, automatic walk. But the ML Tyson have some limitation, that is, it is not specific, and there's a liability of early neurological signs in the earliest stage of accessory adaptation. It requires the repeated assessment, and deformities, just like contractures, may affect the toe. The next one is HNNE, that is Hammersmith Neonatal Neurological Examination. It should be done at the term and the term collected age of for the preterm. It includes the 36 items in 6 categories, having posture, tone, reflexes, movement, abnormal signs, behavior signs, vision, and hearing. It usually takes 10 to 15 minutes. So this is the performer of HNNA scoring. In that, you can see the posture and the tone pattern. In the first one, it is mainly for the posture, how the baby is having on the table or in the crib, arm recoil, arm traction, leg recoil, leg traction, popliteal angle, head control in the sitting, head lag, and ventral suspension. In the second of the tone pattern, you have to compare for the flexor tone, for the leg tone, head control, and the neck and extension tone. Then you have to see for the reflexes, you have to see for the movements and abnormal signs, you have to see for the behavioral signs, vision, and the hearing. In all these screening tests, you will see the upper chart having 1.5, 2, 0.5, 3, 0.5. Those are the raw score. And you will see one gray area. So this gray area shows that the 19th centile of the babies who was normal are doing this. So how to use this score? So any babies with the score is coming in this gray zone is normal. With that, we have to give the optimal score of 1. And any babies who are away from this gray zone, we have to give the optimality score of 0. And it should be done at the same gestational age. Suppose if the baby is of gestational age of 29 weeks, right now on term gestation, then we have to do at the correspondence to the 29 weeks of gestation. We have in the right side, we have the columns of 25, 27 weeker, 28, 29 weeker, 30, 31 weeker, 32, 34 weeker, and full terms baby. So any babies of 29 weeker, you could take 28, 29 weeker. And then we have to see how the posture, if it is in the gray zone, then the raw score is 4 and the optimal score is 1. And then we have to sum of all the scores. So the raw score of each individual items get a score to 1 to 5. If they're in between them, it is 0.5, that's like 1.5. The optimality score is 0 to 1. If they comes in the gray zone, it is as I told, it's 90% of population can do that. So it is normal and the optimality score is 1. If it is away from that, the score is 0. So after compounding all the optimality score, if the score is more than 30, it is no. So a score of less than 30 is abnormal for the term infants, and a score of less than 26.5 is abnormal for the preterm infants. So any two items are in the extreme right neonates needs assessment. And if in the interrate, the ability is 96%. Now, this is the studies which were done by the Isabel et al. That they have seen the neonatal examination by HNN. And that's seen the prediction of 12-month cognitive outcome. In that, they have seen that the early Hammersmith neonatal examination, which was done at 32 weeks of gestation, has moderate diagnostic accuracy for the cognitive outcome at 12 months of corrective gestation age. And the early HNNE have a strong predictive validity than HNNE at the term equivalent age. Now, coming to the short HNNE, it can be done within 5 minutes. It is done by the Romeo et al. And it contains the sum of the part of HNNE. So that can be done at the OPD basis in a short time interval. It also contains the same posture, arm traction, leg traction, head control in the sitting position, head lag, ventral suspension, as well as movements, then motor response and arm recoil. Now coming to the second one, it is a HINE, that is Hammersmith Infant Neurological Examination. It's also done in 3, 6, 9, and 12 month, or sometimes 4, 8, 12 month. It contains 37 items in 3 sections. The first section contains 26 items, with having cranial nerves, posture, movement, tone, reflexes. Second section contains 8 items, and third section contains 3 items. So this is available online, you can see. So in that, the global score is 78, and we have to see the asymmetry. If it is lying in between that of 2 score, it is called asymmetry, and if it is more than 2 asymmetry, it is the worrisome. And for the behavior score, we have not optional score, but we have to write of the behavior score. So we have the first one is for the cranial nerve, second one is for the posture, then for the movement, then for the tone, then for the reflexes, then for the developmental, and then for the behavior. So it was seen that at 3 months of age, the score should be more than equal to 67. At 6 months of age, it should be more than equal to 70. And at 12 months, it should be more than 73. So if at 3 months, if it is less than 56, at 6 months, if it is less than 59, at 9 months, if it is less than 62, or if it is 12 months, it is less than 65, have 90% of sensitivity for the CP. And if the hind is less than 40, there's a more chance of severe CP. So if hind is less than 40, the CP leads to the ambulatory phase, and 40 to 60, it is worrisome. Now coming to the another one, the general movements assessment. So it was now the most evolving things that we have to know. So it is the general movement of the baby that start from the fetal life to the term gestation till 6 to 9 months of age, or half life of the age. So usually it is the complex, occur frequently, last long enough to be observed properly, involve whole bodies in the variable sequences of the arms, leg, neck, and trunk movement. It waxes and wanes in the intensity, force, and speed, and it is gradual in beginning and gradual at the end. It also leads to rotation along the axis of the limbs, and slight changes in direction of the movement make them fluent and elegant. So if any time, if the nervous system is impaired, this general movement, also called as fatal movements, loses their complexity, mainly their quality, and it becomes monotonous and poor. So what is the advantage of this assessment? It is a quick, non-invasive, cost-effective, and it can be done with the recording, and it can be assessed after that. So this is also called a fatal general movement assessment. It is a highly reliable, with a sensitivity of 99%, a sensitivity of almost 100%. You can predict the CP even less than 5 months of age, and you can start the early intervention. The predictive power is equivalent to the ultrasound, that is neurosonologist examination, and also equivalent to the MRI. So this is the normal development of the movement. So it starts from the fetal life, from 9 to 12 months of gestation age, with the fetal and preterm movement. Then it comes to the breathing movement at the term gestation. Then it changes to the fidgety movement, and then at around 3 to 4 months, it changes to intention and the integrative movements. So if any low risk or high risk infants or brain damaged infants, there is a change in the quality of their movements, and any disruption in the corticospinal or reticospinal pathway leads to change the quality. So how it should be done? So baby should be comfortably dressed with the bare arms and leg, and it should be videoed in the supine position for 30 to 60 minutes. The recording is reviewed with the 2 or 3 general movement sequences are assessed. With the experienced persons, they can assess within 1 to 3 minutes also, and it should be documented. So what are the abnormal? The abnormal movements are poor repertoire, cramped synchronized general movements, chaotic general movement, absence of fidgety movement, or abnormal fidgety movements. So these are some videos that we can see what are the different things. So it is the poor repertoire movement, that is due to the lack of the modulation by the CNS. It is monotonous, repetitive, lack of variability, and movement get stuck in between. So you see this video, you will get to know. Now you see the movement is monotonous, involving only legs. It is not going all of the hands and there. And you see that stuck in between that. There's a lack of variability. So it is called as poor repertoire movement. Next is cramp synchronized movement. It is rigid. In this, the all muscles contract and relax almost simultaneously. And if the baby having cramp synchronized movement, the risk of CP is almost 90%. Chaotic movement, it is rare movements. It is a large amplitude movements and can develop in a cramp synchronized movement, and it also leads to severe spastic CP. You see, the chaotic movements, large amplitude and tremulous. Now, fidgety movement, that was normal movements, will emerge as 6 to 9 weeks of post-term age. Will be present obligatory from 9 to 15 weeks post-term. Usually, it disappears as intentional movement predominates, and it is highly protective of the normal movements. It is a small and moderate speed. So you see, this is the normal movements. It includes all of the body parts. It is not monotonous. It is complex movements. So it is a loss. So it is a systemic review that has seen the assessment of general movements in terms and late preterm babies to predict the predictive tools of cerebral palsy. What they have seen, in that they have taken 3 studies with the cohort, one cohort and 2 case series, a total of 118 infants. In that they have seen the absent fidgety movements is particularly high specific for the moderate and severe CP, and it's carry negative predictive value of 98% if it is normal. Whereas if the baby having abnormal movements, just like cramp synchronized movement, it is 100% sensitivity for the predictive value of the CP. This is the chart that we used to follow. You have to see that in that we have done that recording of the movement or see the movement at different weeks of gestation. F is for absent of fidgety movements. You see in the first block, rows, there is absent of fidgety movements. Before that, there is a cramp synchronized movement. So these are the outcome is spastic CP. The second one is the preterm, the 2 weekers. In that, initially there is a cramp synchronized movement at 37 weeks gestation, but after that there is a poor repertoire movement, and in the term gestation they have evolved to the normal general movement. So outcome is the normal. Now, so what it means? So the absence of fidgety movement affect the bilateral cramp synchronized movement or poor repertoire movement. So it is the first asymmetrical sign independent of the head position and segmental movement, which are reduced or absent in the contralateral to the side of the lesion. So poor repertoire of the general movements or finger spreading, lack of movement towards the midline, and absence of fidgety movement and absence of anti-grooved movements are the predictor of the dyskinetic sequence. This is the flow chart that we can see if the movements are normal, or then you have to just follow up. And if they poor repertoire, then you have to follow up the next visit. For the chaotic and cramp synchronized movement, you have to follow up after 1 to 2 weeks to see how the progress are. Now coming to that, what is the cause? So it needs training. The systemic infections, such as infections of the brain, can impair the general movements. Difficult to distinguish between the abdominal movements and the seizures. But it is earlier, if it is done earlier age, it is very useful. and intervention long before the pathological features of the CP develops. So early intervention can be done with that. It is non-intrusive and is cost effective. Now coming to developmental assessment. So developmental assessment is not a predictor of intelligence. It's just to identify the deviation from the normal babies. So what we have to do, the parents concern always has to be take a record and respect it. So you have to start from the history, from observation, and then you have to do the assessment. So there are so many assessment tools. One is CDC tool, one is Denver Developmental Screening Tool that we'll discuss, Trivandrum tool, and other developmental screening tools. So this is the developmental screening tool, that is CDC tools, that was seen in the next slide. But what we are seeing the milestones. The 4 milestones, that is social smile should be done by 2 months of age, head holding should be done by 4 months of age, sitting alone should be done by 8 months of age, and standing alone should be done by 12 months of age. So the CDC grading has done at 4 months, 8 months, 12 months, and later on. So at 4 months, they have graded at 0, 1, 2, 3, and 4, and 5. 0 if there is no head holding, and 3 is dorsal suspension, and they lift the head. And at 8 months of age, no sitting and sit momentarily. Same for 12 months of age. If they are not standing, grade 0. If they are standing, holding furniture, grade 1, and then later on. And so if any baby is having CDC grading of 0, 1, and 2, that is abnormal for the age and go for the early intervention, and 3, 4, 5 is normal for that age. Now coming to the Trivandrum screening tools. It is a simple screening tools. It contains the 7 items that are taken from the Bailey's scale. It can be done or used till 0 to 2 years of age. No any kit required as in the Bailey tools, and anybody, either animal worker, can do that. This is the chart in that we used to do that. It is the bar at different age of gestation with different milestones, and you have to see with that correct gestational age whether they are passing or not. Now coming to the Denver's developmental staging, it is simple tools. It contains 4 sectors: gross motor, fine motor, language, and social. Can be done in 2 weeks to 6 years of age. Can be done in 10 to 20 minutes. And sensitivity is around 80%, sensitivity of around 80%. So this test is done. This looks like that with the gross motor, language, fine motor, and personal and social. With that, one column is also for the behavior. So how to integrate that? In that, they have 4 bars. One bar is for 25, 50, 75, and 90. So 75 and 90 are great, and 25 and 50 is white. So if any baby, you have to first draw a line in that chart, in this chart with the particular gestational age, then you have to see where this line crosses. If this line has crossed that bar, so and baby is doing that thing, it means baby has advanced item. But if that bar is right to that line, and if it's failure or not or refuse to do that, it means it's normal. But the caution when the line which is drawn for that gestational age is coming at the white line, so then it is caution. And if it is left, all things are left to that, it means it is delayed. So normal means no delay or maximum 1 caution. So in that, scanning should be done at the next well visit. If it is 2 or more caution or 1 plus more delay, then it should be done at 1 to 2 weeks. And if the baby refuses, then again you have to do and the re-screening at 1 to 2 weeks. So this is the thing that we have did with the gestational age. So you have to see that in the F is their failure, but the maximum, the gray zone is right to that. So it is normal. If the gray zone is left to that, then it is the caution. Now, these are the different screening tools, the BRODA and the ICMR grading tools. Now, the simplest one is ASQ, Areas in a Stage Questionnaire. It is composed of 5 domains and done by the parents, done by the 1 month to 5.5 years of age. It is parent-centered approach. So it having yes or no, or sometimes with a scoring of 10 to 5. So with that, we have to assess the baby. Now coming to the Bailey's score, it is somewhat taking time of 15 to 1 hours. And having the cognitive, language, in the motor, fine motor, and gross motor. In the cognitive also, in the language also, we have receptive and adaptive, social and adaptive. So this is the scoring system. In that, first we have to see where the baby's correct gestation is. In that, we have a starting point of A, B, C, D, E, F, G, H. From there, we have to start, and then we have to fill up. We have one booklet for that. In that, we have to see for the motor, language, cognitive, social, emotional, and adaptive. For that, all having one row score, then a scale score, and composite score. So for composite score, if it is less than 85, the baby have moderate chance of developmental delay. If it is 55 to 69, severe chance of developmental delay. If it is less than 54, profound of developmental delay. So it can be done at 0 to 30 minutes. And yeah, so this one is the DASI scoring system, that is developmental assessment scale for the Indian infants. It can be done at 0 to 30 months of age. This same like it is somewhat different from the Bailey's. In that, we used to see for the developmental quotient for the mental and the motor development. In the motor scale, we have 67 items. In the mental, we have 163 items. So for the motor cluster, we have neck control, body control, locomotion. In the mental, we have for the visual, auditory, and memories. So by this, we can come out with the developmental quotients. So if the development quotient for the mental and motor is 100 is average, if less than 70 is significant delay. We have to do for the vision assessment, for the ROPS training, and eye examination for after 4 to 6 months, and also for the refraction, establishment, and at 1 year of age, then annually till 5 years of age. We have to see for the red flag signs, that is, if there is no social smile by 3 months, no reach to object by 3 to 6 months, if it is not holding his eye to the objects closer to him, if there's a roving, nystagmus, there's a head tilt, a squint is present in the baby, or milky appearance of the baby. Now, if you have the hearing assessment, all NICU graduates should be go for the AABR. As OAE only take the test till the auditory neuropathy. And the BERA should be done in 10 gestation age. Now, the change of 1 to 3 months, that is, at 1 month of age, the screening should be done. At 2 months of age, the problem should be identified. And 3 months of age, the baby treatment should be started. For the language, we have different scoring system. What we are using is the language evaluation for the Trivandrum. It is a simple diagnostic tool that was done from the Kerala, and it is done with a 3 to 6 years of age. This is the diagnostic view. In that, we have to see the correct gestation age, and then we have to plot accordingly. For the behavior, we have to see for the babies requiring behavior therapy for autism. In that, we have modified checklist for the toddlers. In that, we have to see for the early signs for as excessive tension, difficulty in concentration, difficulty in making friends, school refusal, worries a lot. Other red flag signs for autism: no gesture by 12 months, no single words by 16 months, no joint words by 24 months, and loss of language or social skill at any age. For that, we can do the MCHAT. So MCHAT have the questionnaire of 20s. In that, we have to fill by the parents, by asking the parents. In that, for all the items except 2, 5, and 12, if the response is no, it indicates the age risk. For the 2, 5, and 12, if it is yes, that indicates the age risk. For that, we have to see the total score. The total score is 0 to 2. And if child is younger than 24 months, then a screen again after the second birth. If it is medium risk of 3 to 7, then you have to follow up to get additional information about the risk factor. If the score is 8 to 10, then we have to bypass the follow-up and we have to go for the diagnostic evaluation. So the clinical pulse, so the details discharge summary with all the details of pre-discharge intervention should be carried out and should be summarized. One dedicated team for identification and follow-up of the high-risk neonates should be. The high-risk OPD should be maintained at every week with a structured follow-up. NICU graduates should have at least one H&NE assessment or prenatal general movement assessment prior to discharge. At all the visits, growth, nutrition, and immunization should be strictly followed up. One screening tool should be adopted for the neurological examination and developmental assessment. Formal developmental assessment must be performed at least once in the first year and then repeated yearly thereafter till 6 years of life. Ideally, the follow-up should continue till late adolescent and at least till school, as many cognitive problems, learning problems, and behavioral problems are more common at risk neonates are apparent only on the longer follow-up. And early intervention can prevent disability. Thank you. So if any questions, you can ask. Okay. You can ask questions if you want. Hmm? Wait, stop there.